Okay, thank you very much, Peter. Now we are moving from clinical drama to intracoronary drama. Maria Radu is the European champion of OCT. Welcome, Maria.
Thank you very much, Kari, for that. And ladies and gentlemen, good afternoon. I hope you had a nice day on the slopes. I would like to start to thank Dr. Margolis for arranging this wonderful conference, and also my mentor, Kari Sanamäki, for inviting me here today. I just need to check. Where do we have this one? And, okay, good. So, my lecture is supposed to give you an update on stent thrombosis, and I have chosen to focus today on the mechanisms of very late drug-eluting stent thrombosis as assessed by OCT. Here is my disclosure. So here is an overview of my presentation. I would like to start to make sure that we are still, all of us are on the same line, that we think that stent thrombosis is still an issue, at least I do. Then I will go briefly through the causes of stent thrombosis as we know them today. And my presentation will then most of all focus on a paper that I would like to present that was recently published on the mechanisms of very late stent thrombosis in drug-eluting stents, and finally, what are the implications of our findings and the future directions. So let's start by the clinical outcomes of stent thrombosis. I think that this entity still continues to cause a lot of concern. We can see it here. It has particularly poor prognosis, both in the short term, we can see with a very high in-hospital mortality, but also in the long term, at 5 years, we have mortality up to 2/3 of the patients. At the same time, if we look at different stents from different randomized studies, we can see that the incidence of stent thrombosis continues to increase with time for all the stents, and it seems that like the first generation stents has a higher occurrence of stent thrombosis than the second generation or newer generation stents, which is nicely shown here in this meta-analysis by Palmerini. Now also, later here, actually in January, we had a new meta-analysis showing that this seems to be a problem also in the bioresorbable scaffolds, the absorbed scaffold, in comparison with the everolimus-eluting stents. It's metallic comparator, but I will not focus so much on the BVS today. So I think at the same time as stent thrombosis continues to cause clinical concern, I think it also fascinates us because it has this multifactorial pathology where we have both patient and vessel-related factors contributing to stent thrombosis, but also procedural factors such as, for example, underexpansion, edge dissections occurring during implantation, but then also a lot of different factors occurring during the healing process. We have delayed healing with uncovered struts. This we can see particularly at overlap sites, but also in bifurcations, and especially when we implant stents in the clinical setting of STEMI. Furthermore, stent malposition, positive remodeling has been shown to be correlated with stent thrombosis, as well as recently also neoatherosclerosis. And what is also a little bit typical is that all of these features, they come out many times when the patient stops their dual antiplatelet therapy. So just to put these into the different categories we have according to the Academic Research Consortium, the early stent thrombosis seems to be correlated with underexpansion and different procedural features, whereas late stent thrombosis is more a matter of healing. However, when we come to the very late stent thrombosis, which is thrombosis more than 1 year after implantation, we actually don't have very many studies looking at this. So that's against that background, since we have very limited studies about these mechanisms, the problem is that it's difficult to perform OCT during the acute setting of stent thrombosis because you have a lot of thrombus, and this precludes the visualization of the vessel wall. So it is quite difficult. Furthermore, we have seen, both by OCT and by histology, that we have many different findings, which can be both in the thrombus but also in non-thrombus segments, and therefore it is very important that we understand the spatial pattern of these features, and also that we understand better what is the amount required to get this stent thrombosis. Because all this information, of course, would be useful when we try to optimize stent implantation in order to prevent this event. So the aims of our study were, of course, to assess the mechanisms of late drug-eluting stent thrombosis, and here you can see the methods. It was an international effort, 4 centers, 2 in Switzerland, 1 in Denmark in Copenhagen, our center, and 1 in France. And you can see the exclusion criteria were hemodynamic instability, inability to advance the OCT catheter, and of course, bare metal stents. We wanted to focus specifically on the drug-eluting stents. And here you can see that in the inclusion period, we had 88 patients with very late stent thrombosis. Out of these, 24 had bare metal stents, so we finally ended up, when we excluded those with a poor image quality, we ended up with 58 patients that were analyzable. So our methods were, interestingly, in comparison with other studies, was that we tried to look at the lesion and divided it into thrombosed and non-thrombosed regions. That means that the non-thrombosed region actually functioned as the patient's own control region. Because at this point in time with very late stent thrombosis, it's difficult to find a good control group to compare with. We looked at the standard quantitative and qualitative parameters that we measured, and of course, most importantly, we evaluated the primary causes of stent thrombosis. In the cases where we found more than one cause, we tried to grade the causes from the most plausible, that was the number 1 cause, to the least plausible. And here you see our results. We had the typical patient was a male around 60 years old. The initial is a clinical setting at which the stent was implanted was STEMI and non-STEMI in around 55% of cases. And you can see that 65% of the stents implanted were first-generation stents, 48% were the sirolimus-eluting stent, the Cypher, and then the last portion for the newer generation stents, we had the Zotorolimus, Everolimus, and Biolimus-eluting stents. The total stented segment was around 28 millimeters in these patients. Here you see the demographics at the time of implantation. Sorry, at the time of stent thrombosis, we had an average time of almost 5 years. We can see that at this time point, almost 60% of patients were on aspirin alone. Around 25% of patients had still both aspirin and clopidogrel. We can see that almost 85–90% were non-STEMI or STEMI, and 2/3 of the patients had TIMI zero flow. And in those cases, we allowed to perform some kind of pre-dilatation or thrombus aspiration. So here you can see the causes of the very late stent thrombosis. You see the single highest ranked mechanism, and this came out to be malapposition, which was the mechanism in almost 35% of cases. The second most common was neoatherosclerosis. This was a bit surprising to us. And on the third place was uncoverage. We actually expected uncoverage to come on the second. And then after that, underexpansion and a couple of other causes. So a single cause was found in 43% of cases, and 55% had multiple, that is more than 2. And only in 1 case was it not possible to identify the cause of thrombosis by OCT. So when we looked at these multiple and we ranked them, we could see that malapposition plus uncovered struts was the most common cause of stent thrombosis. We also, of course, performed a stratification. We looked at the first generation versus second generation, but also in the first generation, which of course had been implanted longer time, we looked at those which were earlier within the very late time and those that were later, and we found that there was no difference. Here you can see some strut characteristics in neoatherosclerosis. In the thrombosed versus non-thrombosed regions, we found 8 times more uncovered struts, 13 times more malapose struts, and furthermore, that fibroatheroma, the thick cap and the thin cap fibroatheroma were twice more frequent in the thrombosed segments. Looking at more quantitative data, we can see that the thrombosed regions tended to have, or not tended, but had a significantly smaller stent area and showed a trend towards a lower stent expansion. However, very interestingly, was that there was no difference in the malposition distance or area. And this has been something that was previously very much highlighted in stent thrombosis studies of just late stent thrombosis. So that's very important. Instead, we found that longer segments with uncovered and malapose struts were associated with stent thrombosis. And the length that we found, if we look here at the confidence intervals, was for malposition a length of more than 0.99 millimeters, and for uncoverage more than 1.6 millimeters that were associated with very late stent thrombosis. Just to show you an example of the findings, here we have malapose struts. You can see an example of the uncoverage and neoatherosclerosis, and here we have a 3D reconstruction of underexpansion. Now, what was interesting was that we also constructed these two-dimensional maps where we plotted in, where we had malapose struts, uncovered struts. You can see the green here, that is neoatherosclerosis. And what we did was we looked at the thrombosis, so the brown one is the thrombosed region, and we can actually visualize that the features we had were very well correlated with the thrombosis. So what has this study added to us? Importantly, this is the first study that focuses on very late stent thrombosis in drug-eluting stents, and it's in fact the largest study. Since we published this was just last year, there has been one more study, the PESTO study, but it included also bare metal stents. What is more important, I think, is that we have used a new method. We have looked specifically at non-thrombosed versus the thrombosed regions. We have performed these 3D analysis, looking at the longitudinal extension and also 2D maps. Furthermore, I think also what is new and important here is that more than 50% of the patients had more than 2 contributing factors leading to very late stent thrombosis. And what we saw was that malposition was the most common. In comparison with late stent thrombosis, we saw that uncovered struts emerged as the most common. Furthermore, when we looked at the longitudinal extension, very interestingly, we found these thresholds that are suggestive for further intervention, which would be when you have consecutive malposition more than 1 millimeter and consecutive uncovered struts more than 1.6 millimeters. That would be a sign that you would need to perform some kind of intervention. And finally, also, we found that neoatherosclerosis was very important for very late stent thrombosis. And taken together, of course, we should not forget that we always need to look at the patient from a holistic point of view. We have the 3 main causes of stent thrombosis. We cannot imagine that we can go only for one mechanism. We need to look at the patient from a larger perspective, and actually our study showed that there were several causes, so that's important. Furthermore, if we look at the ESC recommendations, we see at present OCT is recommended in order to assess mechanisms of stent failure with class 2AC recommendation, but I think in the future we will be able to upgrade to a class 1B. Furthermore, if we should use OCT to guide PCI in order to prevent stent thrombosis, what can we learn from our study? Well, I already mentioned with the cutoffs, if we had a cutoff more than 0.99, we could consider to do a better post-dilatation. When it comes to the cause of malposition, of course, we cannot know in our study whether it was acute or it was acquired malposition, but in cases of acquired, you would consider to use the modern drug-eluting stents in order to have a better healing. I will not go through all of this because it's quite logic, but what I would like just to point out is that for the future, I think it's very important that the studies that assess OCT or IVUS-guided PCI, because we have a lot of them just have been published, but also a lot of them going on, is that it's very important that they are designed such that the additional intervention is not at the physician's discretion, but actually follows some intelligent cutoffs and some intelligent chosen factors that you should look at. And at the same time, it's important that you allow sufficient time to follow up in order to be able to say something about the long-term outcomes. Finally, just to show you also what we should do according to logics in terms of stent thrombosis when you have the stent thrombosis, of course. If you have underexpansion, malapposition, or even coronary evaginations, you might consider to do a post-dilatation. In case of edge dissections or neoatherosclerosis, you could treat with another stent or even with a drug-eluting balloon. Finally, uncovered struts and neoatherosclerosis, we should consider medical therapy, for example, double antiplatelet therapy in terms to continue the treatment, or in neoatherosclerosis to be sure that the patient is on good statins. So, ladies and gentlemen, the take-home messages, we saw in our study that OCT can identify the causes of very late stent thrombosis in the majority of cases. We could see that the leading causes of the very late stent thrombosis were malapposition, neoatherosclerosis, uncovered struts, and stent underexpansion. Furthermore, we found that more than 50% of the cases had multiple factors leading to very late stent thrombosis. And in relation to stent thrombosis, the longitudinal extension of malapposition seems to be more important than only the distance to the vessel wall. And in this case, we got this new number here, more than a 1 millimeter consecutive malapposition for intervention. And of course, finally, future studies will hopefully show us how and if this new information that we have provided will be able to affect clinical outcomes. Thank you very much.
Yeah. Thank you, Maria. Just one short question. What do you think, how many % of all stent thromboses are operator-related? I mean, where the cause of stent thrombosis is a bad job from the operator?
Yes, I think the early stent thrombosis are probably mostly the bad job of the operator. But when it comes to the late stent thrombosis, we saw that in terms of underexpansion, which is the factor that an operator can affect, it was around 7% of cases. So, but possibly it's even higher.
Yes.
In IVOS studies, it was never proven that acute stent malapposition is the risk factor for stent thrombosis unless it is associated with stent underexpansion. My question is, how you differentiate if your malapposition that you found at the time of acute stent thrombosis is the acute malapposition or late acquired? Because you have a lot of cipher stents implanted with stent thrombosis in your study.
So you said at the time of early stent thrombosis, yes, or at the time of late?
Late stent thrombosis.
At the time of late. So in fact, you cannot do that if you do not have serial data. Yeah. However, if you have been looking at thousands of OCTs, you can get some kind of clue whether this was due to acquired or persistent malapposition, because it looks a little bit different, and at the same time you have to look at the expansion, because that will also probably be able to tell you. But if you want to be 100% sure, you have to have a serial analysis.
Yeah, Lisette.
Thank you for a nice presentation, Maria. Your data showed that the area of malapposition was not a predictor. It was malapposition, but not the area. Do you think there's a limitation in your data or in OCT? I mean, if you have 3 stent struts which are malaposed, do you think it's more important than if you have a big aneurysm? We can see by IVOS, sometimes we see that patients coming in with a stent thrombosis, they have an aneurysm. Also in the setting with the stent thrombosis, the patient often has a lot of thrombus in the lesion. Do you think there's a limitation that you can just not see the area of malapposition with the OCT?
Well, I think it's a good point that you bring up, but at the same time, so we did not have very many evaginations in our studies. We had a few, but what we saw when we were looking at the area, so in those cases, we would go in and have a look at the material that is there. Is it thrombotic material? And that would be able to, that will help us to diagnose whether we are dealing with just a malapposition or we're dealing with a positive remodeling. To look also longitudinally, not only at the cross-sectional level, but longitudinally in order to give us a clue.
I have 3 short questions.
But maybe you can put this in the one.
I can
In the
put it into
middle.
one.
Yeah.
How late was late? How long was long?
Jim, and then one.
Huh?
Okay, Jim. Yes, please.
I think this is an important paper.
It is.
It's worth spending a little extra time on it. How late was late? Were these years out, or were they?
Yes, it was the ARC definition. So the late is between 1 month and 1 year, and the very late is beyond 1 year. And in our population, we had a median time of 4.7 years.
Okay, and how long was the longest male apposition? Were we talking several millimeters, or?
Yes, the longest, I believe, was around 4 millimeters, yes.
Thank you.
Thank you.
Excellent presentation. How did you do these 2D maps? Is it a special software or?
Yes, so right now it's called, I believe it's called Pudicom, the software, where you have to plot the struts. So you do them, you have on the x-axis you have the length, and on the y-axis you have the degrees. So if you start from 12 o'clock, from 0 to 360 degrees, and you simply define each strut, is it covered, uncovered, malapposed, and so on.
Okay, thank you very much. I also have many questions because we are core lab of OCT, and I'm a bit okay, but this will be too long discussion because I guess we need to continue our, the evaluation and research in this field. But it's very interesting. Thank you very much.